All right, so welcome to Journal Club for February 6th, 2019. Anyone have any interesting cases? Just no names of hospitals, agencies, people, dates, times, those sort of things.
Yeah, I have one. So I had a female patient, mid-30s, come in who actually was a sign out to me. So the story I got was in AD that this patient was in police custody, being taken to jail, not officially booked yet, but on her way. And en route, she said to them, "I feel like I'm going to have a seizure." Known seizure disorder, didn't actually seize, just said she felt like she was going to seize. So they brought her to the ER. So we were kind of observing her in the ER per the physician that signed her out to me. She had a UA pending and a CT head pending. And the CT head, I guess they had done because she was acting a little bit kind of out of it earlier. Long story short, the sign out was follow up on the UA, follow up on the CT head. If both are negative, she can be released back into police custody. So the night kind of got a little crazy busy, and she ended up hanging out a little bit longer than I intended, but she was doing fine. Her vitals remained stable the entire time she was there. When I finally got a chance to look at her labs again, she had a urinary tract infection. So thinking that she was going to be going to prison, I treated her with an IV dose of antibiotics, ceftriaxone, thinking that maybe she wasn't going to be able to get the oral antibiotics filled right away. So the antibiotics were ordered, and maybe about an hour later, the nurse comes to grab me to tell me that there's something wrong with that particular patient. And I was, I'm not really sure. I hadn't actually even spoken to her more than 2 words because every time I checked on her, she was sleeping. So I go in the room, and she's now tachycardic, hypotensive, and hypoxic, and she's got this new blanching erythematous rash on all of her extremities that was not there previously. She was kind of sleepy but arousable, and she was able to answer my questions so far as for me to say, "Do you have any allergies to antibiotics?" And she says no. And I said, "Are you having trouble breathing?" And she says yes. And that was pretty much all I got out of her. And I also did ask her if she used anything, illicit substances in the meantime while she was in the hospital, and she denied it. So this patient was like a textbook anaphylactic allergy, and ended up getting 2 of the sub-Q epi 0.3 milligrams, and then we made the decision to intubate her because her vitals were not improving and she was headed towards that anaphylactic shock diagnosis. Interesting thing, and the reason I bring it up was because there was no evidence of airway swelling. It was all based on her vital signs and her subjective sensation of dyspnea. She did have a little bit of expiratory wheezing on lung sounds, but when I kind of opened her mouth and looked at her tongue, there was really no obvious swelling, and there was no uvular swelling or soft palate edema that I could see. She was a pretty straightforward tube. I didn't have any issues with it. So I don't know if you guys want to chime in and say when you would or would not pull the trigger in terms of intubating somebody with a potential anaphylactic reaction. It was kind of an interesting case that patient was supposed to be signed out and go back to prison, and she ended up in the ICU. So.
Anyone? So the big things with anaphylaxis that we worry about is, first of all, what is anaphylaxis? You want 2 organ systems, so hypotension and hives is good enough for me. Shortness of breath and something else, still good enough. It's easier when they have a previous diagnosis that they're allergic to something, or some people just have allergies, period. They don't know why. Personally, I think I am, but that could be a little hypochondriac as well. I've never been stung by a bee, so I'm always very concerned about that. But the second is, do not stop the therapy that's going to help them, and that is epinephrine.
Right.
Don't give the Benadryl that's symptomatic. Don't give the other medication. That's fine to give it, and it makes them feel better, but the thing that's going to reverse the anaphylaxis is the epinephrine. So nothing should come between the patient and epinephrine. I like to give it IM. There's various things out there that say, sub-Q versus IM. I give it IM. Also, I give it for respiratory, but that's another issue. And you actually can see people just they take a deep breath, and you can actually see the hives go away, things like that. The Benadryl is symptomatic. It helps with the itchiness. The Pepcid is just theoretical blockage of H2. Ranitidine, some people give. I send these people home on cetirizine, and I write them a prescription for an EpiPen, and also I train them on how to use it. I have an EpiPen trainer. Now, there's I think, was it last year or the year before? They had that big thing about how EpiPens are too expensive. You know, you can give a generic. Other places are actually, especially agencies, BLS agencies, are now carrying epinephrine in a glass vial with a needle, and it showed. We reviewed articles where it showed cost reductions in the hundreds of thousands just by switching over to the vial versus using an auto injector. Some hospitals, some agencies will just use auto injectors because it cuts out the guesswork. It cuts out that, oh crap, someone is having this emergency, let me just give them medicine, and then they give them too much. Or they give it IV, or something crazy like that.
So I missed the first part, I'm sorry. How much epi did you end up giving?
So she got 2 doses sub-Q before I intubated her, and then her vital signs significantly improved. If they hadn't improved, then I would have started a drip. So I called the ICU, talked to them about the patient, and I said that her vitals have significantly stabilized in terms of her hypotension, which also probably was helped by the fact that I used ketamine for an induction agent. But I had also started IV fluids, and I said I would keep an eye on her pressures and her vital signs and start the epi drip if it felt that it was indicated, and they were okay with that. They didn't want me to start it.
How much epi did you give?
So 2 doses of 0.3
Sure.
IM.
Okay. So you give IM, not sub-Q?
Correct.
Okay.
Sorry if I said sub-Q earlier.
Yeah, so IM is always the best route,
Yeah.
right? We know over sub-Q. So for me, you know, the range for epi you can do is 0.3 to 0.5, right? So for me, if I'm having to pull out a big gun like epi, I'm going to go big. So I never now give 0.3 of epi.
You just give
I give
0.5
0.5. So I always give 0.5 of epi. If I feel like someone's in anaphylactic shock, and I've had probably about 3 in the last couple months now, where I had one interesting case where we had one patient who actually got fentanyl and had a severe anaphylactic reaction right in front of us, and we went straight to, you know, epi, IM, didn't give any other medications, Benadryl or anything like that, went straight with epi, and then the next drug I gave was 20 mics of epi, IV. And then I gave her another 20 mics, and literally within 3 minutes she was 100% different, 100% changed, and her blood pressure improved, her symptoms completely improved, and she was no longer
Where'd
symptomatic.
you get the 20 mics dosage from? Were you just doing like push dose?
So I did push dose, right. So, you know, basically I had push dose epi, and essentially what I did was, you know, the way I make my push dose epi is essentially I get 10 mics in 1 ml.
Right.
And so I usually, you know, you can always give 10 to 20 mics. I just go, if I'm a kind of a go big or go home kind of guy. So if I'm going to give the push dose epi, I'm going to give you at least 20 mics. And so I've used this now 3 times in like the last 6 months, and each time I've done it, I've never had to, you know, thankfully, you know, knock on wood, have to go down the route of, you know, taking an airway. And patients usually improve significantly, and this isn't like the anaphylactic patient. So I mean, I'm a big believer in going with epi. And then on the back end, after everything got better, I was like, okay, you can give the Benadryl, you can give the Solu-Medrol if you want, you can give any of the other stuff, but really kind of turning that patient, the key part is really kind of just pulling the trigger and going with the epi IV.
Did you, sorry, just to clarify, were you using the cardiac dosage of that for the push dose epi? Were you using the, okay.
So usually it's the 1 to 1,000 is what you want to use, you know, for, it's the 1 to 10,000 doses of what you're going to use for IV concentration. It's just because it's just, you get a larger quantity, and so you can actually concentrate a little bit better. If you get the 1 to 1,000, what ends up happening is for you to mix that and concentrate it to the what you want, it's just so hard.
Right.
So for IM purposes, obviously we do 1 to 1,000, and then for IV purposes, we want to do 1 to 10,000. So it's the 1 to 10,000 epinephrine that we use, and then we constitute that basically with, you know, 1 ml of the 1 to 10,000 and 9 mLs of saline, and that gives you a 10 mic solution. Yeah.
Yeah, I was lucky to have extra like hands nursing staff wise, and
Sure.
so they were able to kind of do everything at once. I mean, I did order verbally the Benadryl, the Solu-Medrol, all that stuff that's not given right up front, but I had enough people to give it, so they were able to give it. And then I actually, one of the other attending that was in the ED kind of was, it just happened to be seeing patients around this one and kind of saw what was happening, poked his head in, and we kind of talked about it. And she just wasn't coming around like mental status wise either, and so that was another element element of why
Yeah.
I ended up taking her airway.
Yeah.
I'm not sure if some of that was supratentorial in the patient, but ultimately I felt confident in the choice that I made because it protected her airway. She was very stable for the remainder of her time in the ED, and then she actually got extubated later in the evening the next
Yeah.
day. So I think it was the right choice. But I agree with you. I think epi is the primary thing that we need to
Yeah.
give, and a lot of us focus on the other stuff.
And we always shy away from giving epi. I think it's something that we fear of. And I mean, what's the worst that can happen? Worst that can happen really is you give someone a STEMI.
Right.
And that's happened. I mean, we've had patients who we've given ST depressions to. We've had people who've actually had chest pain from epi. We've had people who've actually, I think Dr. Tanis had a patient who he had a patient who he gave push-dose epi to so much that they ended up getting a STEMI on their EKG. So, that happens. But the thing is, it's like, what do we care about more? Do we care about, saving that life and then kind of taking that patient to the cath lab later? I'd probably take my bets on that any day of the week versus the other.
Yeah.
Yeah.
It's
And
very
I
easy
agree.
to come in after the fact and say,
Yeah.
oh, you shouldn't have done that, but the
Yeah.
patient would have died if you didn't.
Right.
Right.
And mental status is huge, like you said. I mean, looking at someone's mental status and deciding when to take the airway is huge. And I mean,
she
that's
just
kind
wasn't
of,
perfusing, and
yeah.
it just seemed like she wasn't perfusing her brain. I was like, we have to do something. So,
Right.
yeah, she ended up doing pretty well. So,
The last 2 points that I want to make on this case is that don't be afraid to give that second dose of epi. And actually, a lot of auto injectors now actually have 2 doses built in. The second one is starting the epi drip, especially if it's working and then they're relapsing now, especially on your way to the hospital. Starting an epi drip is something that can help these people. Or if they got a little bit better but not quite all the way, starting an epi drip also helps, and it's a very low dose. A lot of the wilderness medicine, we talk about, what if it's expired? What if this? What is that? If you have nothing else, like I would give it to myself. I don't know if I would give it to a patient. It's kind of a decision you have to make on the scene. Any interesting cases?
I got one. Actually, this was a patient I had that I delivered to my colleague here at the hospital. So it was a pre-hospital, late 60s male, history of AFib, CHF. I was close by, so I responded. It went out as difficulty breathing. I got there, he wasn't having any difficulty breathing, but he said he was just severely nauseous. He had no chest pain, no shortness of breath, nothing else like that. He just woke up in the morning and just felt really nauseous. BLS was there at the time. They were trying to get him manual blood pressure and feeling his pulse, and they're like, oh, I think he's having I'm having trouble finding his pulse and feeling it. So I'm like, oh, that's interesting. So let me put him on the monitor before ALS got there. So I put him on the monitor, and he was at a rate of 28. So he was really bradycardic. It was hard to see P waves, so it was because he kind of had like baseline either something going on in the atria or he was just trembling so much to see if it was actually like a 3rd degree block. But it was narrow complex in the 20s, but he was mentating fine, had a good blood pressure. And then medics walked in at the same time, so they're like, oh, this is really bradycardic patient, so we got him hooked up to IV, put him on the pacer pads, we gave calcium, we gave atropine, and tried to bring it up a little bit, which really, none of that worked. We got him in the back of the ambulance, and we did another EKG. Oh, we did a 12-day on the scene. It was same thing, sinus bradycardia. And we got him into the back of the ambulance. We did second EKG, which now is saying meeting STEMI criteria. So there was some very mild ST elevations in V1, V2, so it was maybe like a millimeter. I wasn't exactly sure to call it. I mean, when we notified the hospital, we told them that it's there, but we weren't 100% sure if we want to activate the cath lab for this, but they let them know right away. At that point, he started to become a little hypotensive. Blood pressure dropped, so we used push-dose epi, which improved the rate as well as the blood pressure. Still no chest pain or anything. As we pulled up to the hospital, I got out to tell them, and he has like a 7 or 8 second pause. So it just went flat. So we just started pacing him right away as we were walking into the hospital. And then as we walked in, there happened to be an electrophysiologist there, and my colleague here. So they put in a transvenous pacer,
Nice.
like within a few minutes. So
That was cool. And then as soon as the EB physician put the temporary pacemaker, I mean, his blood pressure improved, and then it was so stable. And then basically.
And that's without pacing. Just the act of putting it in, his heart went back.
Interesting is his labs, everything was actually normal, right? So we don't really know what caused him to be into the complete heart block. But he actually ended up in getting this permanent pacemaker next day. It looks like he did well after that.
Why did you decide not to pace initially when his blood pressure dropped? Like, I know the push dose epi helped, obviously, but
Yeah.
when he became hypotensive, why not start pacing at that point?
So he was still mentating fine, even though his blood pressure started dropping. So, I mean, we were headed that way,
Sure.
but he was really reactive to the epi.
Yeah.
So, it was really just a slug, and then he came back and was normal.
It kind of reminds me of that conversation we had with Dr. Merlin maybe over a month ago about a patient that I had that was like awake and talking in VTAC, whose vital signs were unstable, but they were alert and oriented, and he was saying he would medically treat the patient that's still perfusing their brain before he would use electricity, even though the book says electricity if they're unstable on paper, that kind of thing. And that patient for me actually did end up going from VTAC to VFib when I used electricity, so that was not ideal. We got it back, everything was fine, but like I agree though, I think that's a thought process you have to make.
I think, I'm sorry, go ahead.
No, I was just saying VFib is better than asystole.
I mean, true, you're not wrong.
I mean, a lot of times we're fearful of like, and we treat the vital signs so much, and we don't take a big picture about the actual patient. And a lot of times, as much as we talk about what does the text say, and when do we cardiovert, and when do we chemically convert someone, and really it is really managing the patient, and it's kind of just being a little bit cavalier in kind of these patients, and it's hard because we don't see them so often, so it's a little bit challenging because when you see these patients so less frequently, it becomes a little bit more tasking. Ideally you had the pacer pads on the patient, so if you needed to, you could pace them right away, and then if we were in the ER, what would we do? We'd put a cordis in, and we'd have pacer wire ready to thread in case this patient required any type of transvenous pacing. So that's always ideal as well. One thing that I had mentioned to you, remember before, it was like, it's always interesting it's like a double-edged sword when you have a patient who might meet like STEMI criteria, and now who's becoming hypotensive, and you have to give this patient epi. Because now we're thinking, this patient has an ischemic heart, and there's ischemic disease going on that's causing this patient to be in like a third-degree block or bradycardic rhythm. And so if you press this patient and give them epinephrine, this in fact could probably worsen their kind of symptomatology as well. So it's a double-edged sword, and so it's challenging sometimes with these patients and what's the right kind of thing to do. But they responded well, and that's great. But really kind of following mentation is huge, and just saying, okay, this patient's mentating, and I think that's the right step to take. We can coast this. Most people wouldn't be comfortable, but I think that's the right way to kind of to take it. And then this patient would probably get a TBP, and who wants to get shocked and paced when they're awake?
Right,
I mean, it's just not pleasant,
Yeah. I think at the same time I was also pulling out the Levoped, which the medics weren't really familiar with pushing. I mean,
Sure.
I know it's silicatycholamine, but you probably get some inotropy from it as well, I think. So I pulled it out, but I know that we normally give it in like micrograms per like minute. So I guess we figured the way to do it was just spike it into a bag, like 250, and then.
Preferably have that math done beforehand.
Yeah.
So the cheater's way is typically you want to, get depending on what the concentration is, but you set your concentration, and then what you do is, most people pre-hospitally, they don't use pumps, right? So what we do is we look at drip rates. And so we've been trying to create a protocol for Levoped, but essentially what we're doing is we're doing it based on a drip per second to see how many, basically if you're having a drip per second, and that will be equivalent to how many, micrograms per minute of an epinephrine drip. But that's typically what we do is just basic science and kind of trying to estimate. It's not exact, but it's as good as it gets pre-hospitally. That's the other option versus going to a pump.
The key things from like this case that we wanted to touch on was, when you see the patient and you can't feel a pulse, first thing to do is talk to the patient. Like, are you okay? And if they say, I'm fine, then you can take a breath. Sometimes I'll feel my own pulse. Because one of the things is, especially when your adrenaline's going, if you're pushing too hard on the carotid, on the radial, you're going to occlude the vessel and you're not going to feel anything. The other thing is, as soon as you put them on the monitor, you saw that there was bradycardia. First thing first, you're looking for that P wave. Is there a P wave? Is there not? Is it regular? Is it irregular? Those are the things that kind of help us differentiate. And you said that you pushed calcium and atropine?
Yeah.
So that's perfect. Calcium, why did you push the calcium?
Yeah, I mean, he didn't have any I didn't see an AV fistula, I didn't see anything in his history that looked like he was like renal patient, but like just in case he is hyperkalemic.
Exactly.
It doesn't hurt.
Exactly. Is it going to hurt them? No. But can it reverse all this like right away? Yes, we've all seen it. I think we've reviewed it several times here that hyperkalemia causes these arrhythmias, and as soon as you push the calcium, everything goes back to normal.
It's the syphilis of all EKGs.
Yes.
If you had a patient who you knew was not hyperkalemic but was having intermittent runs of bradycardia, would you still give them calcium?
Yeah, I would give it.
Yeah.
Absolutely. I mean, there's no harm to giving elemental calcium to a patient, right? I mean, what have we seen as a side effect profile? If you slam it in a patient really fast, they'll get nauseous. Sometimes they'll vomit on you. Some vagal, but that's about it. So, I mean, giving it slowly is perfectly okay. And, I mean, otherwise, there really isn't any deleterious effect that you can give to a patient by giving elemental calcium.
Some people will give it before they give cardizem to raise the blood pressure. I don't know if that actually works, but I still do it. And how much, so what's the difference between calcium gluconate and calcium chloride? Anybody?
One you can give peripherally, one you can't.
Oh, both of you can give
I
peripherally.
mean,
You just
not
prefer to give
supposed to,
the
yeah.
chloride
Through a
centrally.
central line, yeah.
But what's the big difference?
The amount that you're getting.
Yeah.
Yep, it's down to biochem. Anybody? So with calcium chloride, you're getting 3 times as much calcium.
Right.
So
Whenever you want to give it, if you're going to give calcium gluconate, if you want to get the same efficacious amount of calcium chloride, you're going to give 3 amps of calcium gluconate to 1 amp of calcium chloride. And, I mean, code carts across the world and paramedics across the world are giving calcium chloride peripherally. There should be no reason why we can't give it peripherally either. Cool, good case.
any other interesting cases?
I have other ones. Did you want to talk about? No? Okay. I guess I have one that we can piggyback off of, going off the arrhythmias. I had a gentleman came in same night, ironically, as the patient who ended up in anaphylaxis, this guy was in his 60s, previous coronary artery disease with like 3 stents on, I think it was Eliquis, some NOAC of some kind, and antihypertensive medications. Says for the last week or so he's been having episodes of like nausea, diaphoresis, chest pain, and lightheadedness, and they last for maybe 30-45 seconds, and then he feels a little bit better. The chest pain that is residual goes away with nitro. And I guess the night he came into the ED, he had an episode that lasted longer than the previous ones. He wasn't able to complete his ADLs because he was so uncomfortable, so he came to the ER. Vital signs totally stable on arrival. He was one of those people where I had like 20 people come in at one time, and so you read the triage note and you put in orders based off of what you're reading in the triage note, and then go and see the patient in a few minutes maybe. And I actually got pulled out of a room to go and see this gentleman. This was 2 hours maybe after he had already been in the ER. And I get over there, and as I'm walking up, like 5 nurses swarm the room, but he's still awake and talking, so I wasn't sure what was going on. And one of his leads had come off, and they finally get the other lead on, and he's in this, I don't even know how to describe it to you. It looked like he had like 2 tiny little bumps on his EKG, like 2 little like hills, and a rate of like 28. And still awake, still talking to me, says, yeah, I'm having some pressure in my chest. And I was like, yeah, you probably would, because your heart rate's like 28, and now my heart rate's like 150. And so I had them bring over the EKG, and I was like, let's get an EKG. Somebody please grab me some atropine, because I couldn't really see what was going on other than that it was crazy bradycardic. And by the time they got the EKG machine over, it had totally resolved, and he was in a normal sinus rhythm with a rate of 70. So that was the EKG I got, was normal sinus rhythm, no evidence of ischemia or ST elevation that I could see, and he was mentating the entire time, doing fine. And we were like, maybe we should move him to a room closer to me. So we moved him to a larger resuscitation room. Patient felt fine other than chest pain, and he was actually requesting nitro, and he's hypertensive now that his heart rate came back up. So we gave him a sublingual nitro. He said, I feel much better. He's chilling in the bed, and an hour and a half goes by, no issues, and then he has another episode of this bradycardia again, but not long enough for me to catch it on a 12 lead. So I had the atropine there at bedside, but I never ended up pushing it because these episodes resolved so quickly, and he was never hypotensive. He was never not like mentating well. And I made the decision to, obviously I called his cardiologist, and I put him in the CCU because I was like, at some point maybe this arrhythmia was going to be lasting long enough that it would warrant like floating a pacer and that kind of stuff. We obviously put the pacer pads on him, and then finally, when I got him admitted, the inpatient team put in a standing order for the atropine, and then right as I'm about to leave for my shift, he has this third episode of this bradycardia, and it resolves again. This time they did push atropine because they had a standing order and the nurse felt uncomfortable, even though he was still mentating fine, right? Then they get a repeat EKG, 30 kg, and now he's got an acute inferior wall STEMI. That wasn't there before.
Wow.
So it was kind of interesting, like, I don't know if it was like a brewing STEMI this whole time, and that he had some partial blockage and that was causing the irritability and causing the arrhythmia, or if the atropine caused some sort of ischemic response and that finally was what pushed him over the edge. I'm not sure. But they ended up taking him to the cath lab, 100% RCA occlusion.
Wow.
So,
I think it's probably the latter, that something occluded it and, just going up, having that, it was irritable
yeah.
and causing. I was just say that the patient was probably going to go for an EP study the next
That's
day.
what I thought too. That's part of the reason why I put him in the CCU. And he had self-dosed like full dose aspirin prior to coming into the ER, so I didn't give him that. And I actually went back and like double, triple checked the EKGs like from prior in the evening because I was like, did I like miss something? But there was nothing there. It was kind of an interesting progression of events. I don't know. So again, I guess it goes to speaking that I don't feel like I did the wrong thing by not giving this guy atropine because he had come out of the arrhythmia so quickly on his own and never lost his mental status, awake and talking the entire time. I felt like it would have been overkill and it would have made him really uncomfortable.
Oh, absolutely.
So-
I always feel that, if the patient's talking to me, I don't need to treat whatever's on the monitor.
Right.
It does get uncomfortable though.
Right.
And you're just like, you haven't had a heartbeat in a while.
And so this was the guy that I was kind of like alluding to earlier. I did not give him calcium because his potassium was normal.
Mhm.
So I had all of his labs back before I was able to go and see him, and so his potassium was normal. So I guess I just wasn't like thinking about it because the bradycardia had resolved. But now I'll think about doing it next time. So.
It could help with myocardial, irritability,
Yeah,
but the evidence for that is not great.
sure.
You want to jump into the articles or?
Quick case, you want to talk about it?
Yeah.
This was actually, I think, our first pre-hospital blood case, right?
Uh-huh.
We were dispatched to an elderly woman. She was 85. She was in the back room of a house, and family heard screaming, went back to investigate it, and the dog actually started mauling this 85-year-old lady. Just ripped her leg apart. She had a both bone fracture of her lower leg and twisted and through, macerated tissue, large amount of blood loss, and then her right upper extremity also was bit on the forearm. Both bones fractured and through the skin and twisted, and blood was just pouring out of her. The family unfortunately actually shot the dog in the head. So it's something to think about on your scene safety, is because now we have a vicious dog on scene that was mauling this 85-year-old lady who was shot in the head by the family, and then now you have an unsecured scene with a handgun and loaded handgun on scene. And so police showed up. They secured the dog, made sure the dog was out of the situation, and the gun was secured. They applied tourniquets to her leg and arm, and her initial blood pressure when the medics got her was in the 50s. She lost a tremendous amount of blood. They controlled her bleeding. They RSI'd her appropriately with push dose pressors and a ketamine induction. and got her intubated. And our EMS, our physician team met them at the LZ, and we actually started whole blood pre-hospitally. And she got a unit of whole blood, and I brought the stuff in to show them, this is the blood box where we keep our blood in. Our blood administration kit that has the Y tubing and the flushes and the heat packs, and the blood's actually refrigerated at 30 to 40 degrees, and to warm it up, we were using hot packs and stuff like that in the absence of a commercial, fluid warmer. But the patient did well. She went to, she got in a helicopter and was brought to the trauma center. She went into surgery immediately. We briefed the surgical team that we gave her whole blood pre-hospitally. They were very impressed. And on her arrival to the trauma bay, she got the massive transfusion protocol, as well as, a unit of whole blood. She lost her leg, survived this initial surgery, is probably going back to the OR for an amputation of her right upper extremity, but looks to survive the incident. It was quite a scene. She lost a huge amount of blood volume out of it and was resuscitated with TXA and whole blood and ketamine induction, intubation, and 2 tourniquets, one on each extremity, and then transported to the trauma center. It's quite a scene.
Yeah, so a couple of things. Biggest thing is scene safety.
Yeah.
Go into a scene where there was gunfire, that there's a possible animal. I think I remember once I responded to a national park, and it was
Bear.
Yeah, essentially it was some sort of cougar or some sort of animal attacked the dog and the person, and both were mauled, and both and it's just well, is it safe?
Yeah.
And they couldn't tell me. I'm like,
Yeah.
luckily they were rangers. Rangers are actually armed. I did not
right.
know that at the time, but so that we were able to retrieve the patient and get out. So
This was a large dog.
Yeah.
It was a pit bull, and these animal attacks, whatever flips their switch, man, it is a brutal, unending attack. It's not like a little snap and move on. This dog was lost, his civility, I guess, or and tore this lady's leg up. Literally twisted it up backwards. Large chunks of meat ripped out of her calf and her muscle. Her vasculature was destroyed. Like I said, both bones sticking out of the arm and a leg. Horrendous scene. The floor, the tile floor was just covered in blood.
and the big things that that the new stuff, the low titer whole blood. No, minimal saline. You can give a little saline for to keep the vein open, things like that. You don't want to lose your line, but really the whole blood is what makes a difference. It brings the coagulation factors in. It brings the oxygen carrying capacity. In the trauma bay, if we put in a chest tube, we can also auto transfuse that. Not ideal, but whole blood is better. TXA tourniquets for the legs. I like to use double tourniquets on the legs, just because there's just so much tissue there. The first one you're not going to get as clamped down as you want, and it's really that second one that's going to really take care of it.
Wide. It doubles the width of it too, because the tourniquets are only 1.5 inches wide.
So some of them are very, very narrow. I don't like those. But any tourniquet is better than no tourniquet.
That's right.
And that's why, for us, when we're treating patients or when we have our TAC gear, we carry multiple tourniquets. But in reality, everyone that we work with usually has at least one with them, and it should be in a place where you can reach it. And you use their tourniquet on them before you access your own.
So I just recently learned this as well, is our units, our primary EMS agency that we work with, actually has UASI grant funded massive bleeding control kits in the ambulance, and we now have one in our primary vehicle. It's a bag. I can show you a picture of it. It's about this big. It's got 4 individual smaller zippers in it. Each one has 4 tourniquets, 4 Israeli bandages, 4 quick clots, so a total of 16 tourniquets, Israeli bandages. That's on our primary vehicle now.
Airways as well. They have nasal airways.
Yeah. So this is what's on each of our MICU units. I didn't realize this. I don't know if everybody does, but that is available, and we have that.
We're rolling out slowly. And also these kits, though, are these the ones that each packet is designed for you to grab and toss to someone?
And break away.
And basically take care of one patient or one set.
So you can distribute this
Yeah.
for bleeding control devices, or 4 sets of bleeding control. And when I say by a set, it has quick clot to pair with an Israeli bandage to pair with a tourniquet times 4 for each small modular bag, and the larger bag has a zip with 4 components, so you can distribute them out in a mass casualty situation. Because this day and age, these are popping off all over. Every major city has a tale of a horrendous episode where there's more than one person hurt, and bleeding control kits are turning into the norm. But this is an example that this is how you resuscitate a bleeding patient pre-hospitally. This is the future. Tourniquets, TXA, whole blood, minimal crystalloid, airway control, and source control.
And one thing that we do that not everyone else does is you can actually take your ultrasound machine, you can take things like that, you can ultrasound, you can have people put tourniquets, because when you put tourniquets on, unless you train all the way, in real life you're not going to do it. You're going to tighten it up and then you're going to stop too short. So you can actually use your ultrasound machine, or you can feel for the pulse, and you should be going until that pulse is gone. Don't keep it on for too long, but especially when you're training.
Listen,
but it hurts like hell.
And there's a theory behind that, because an improper tourniquet, this is important. So an improper tourniquet will clamp off the venous return in a limb and worsen your bleeding, because the arterial pressure in your limb is higher than your venous return. So if you put a partial tourniquet on, you stop the return and you increase the blood flow out the hole in the body. So you have to completely clamp it down to stop the inflow into that limb. And that's the key point that Navin's saying. It's never too tight. It has to be as tight as you can get it. Because if you just block off the venous return in a vessel, in a limb, you're just pumping blood into and out of the body.
Well, this is a great case. I mean, unfortunately, we hate to have cases like this, that we have to, really deal with. But, if you're going to, be on scene, and utility of an EMS physician to be on scene is to, be in this type of situation where we can actually do, advanced trauma resuscitation. And I think this is the ideal way to resuscitate a patient. We look at literature and we see that, if this patient's 85 years old, and if they're, what would they have done ideally if medics were by themselves? They don't have, this patient's hypotensive and initial blood pressure in the 50s. I mean, what are you going to do? You're going to give crystalloids, and what's going to happen? You're going to decrease coagulopathy, right? You're going to worsen this patient's acidosis. You're going to pop the clot. They're not going to actually bleed. You're going to freeze them. I mean, all these things are going to happen. You're going to worsen this patient's condition. You're going to worsen their acidosis, and a patient who's already 85 now, who's going to go into an OR in a worsened state and bleeding out. I mean, it's this is what we've been doing wrong all this time. And to kind of move into a direction where we stopped the bleed, we gave whole blood, we resuscitated the patient, and now this patient has gotten not only blood, but also plasma, platelets.
Clot.
I mean, now we're going to have clot formation, and now we can take this patient to the OR.
Keep it with TXA.
Yeah, to a couple with TXA. This is advanced resuscitation, and we talk about the damage control resuscitation. Now this is the next step from that, and I think this was a great job and a great resuscitation on your end.
Yeah, it worked out well.
Yeah.
All right. Articles? Who wants to go first?
Again.
Huh?
So the first
Which one?
The one with the effect of the dispatcher-assisted CPR.
So this is actually something that came up, 2 weeks ago, and I said that we're going to get the article, and we'll talk about it then, so. Go.
All right. So we all know that bystander CPR is really key factor for the survival of the out-of-hospital cardiac arrest patients. And then so the dispatcher-assisted CPR has been implemented in many countries, including Korea, and where this study was done. And it looks like some study shows that there is a bystander CPR improved the neurological outcome, but it's still unclear how the dispatcher-assisted bystander CPR improves the neurological outcomes. So that's what they look into with this study. So this study evaluated the impact of the dispatcher-assisted CPR on faster defibrillation and loss, leading to the being discharged alive. So this was cross-sectional observation study using the nationwide OHCA registry database in Korea. And then since only the physician can pronounce death in Korea, all EMS assessed patients with OHCA are being transported to the hospital and with the medic perform the CPR in ambulance. And in Korea, emergency medical services technicians are intermediate level and EMS system are fire-based, sounds like. And then they started this dispatcher-assisted CPR back in 2011, and then they implemented nationwide in 2013. So they looked into the data, and then all EMS treated adult patients with OHCA, who is believed to have the cardiac ecology, were included in this study. And then, but they excluded the patient who did not receive any resuscitation attempts, or those who were witnessed by the EMS personnel, experienced an arrest at the primary care clinic or long-term care facility, or patient who received the defibrillation before by the layperson before EMS arrival were excluded. So their primary outcome was lost within 90 minutes, leading to being discharged alive from the hospital. And their second outcome was lost within 90 minutes, leading to be discharged with good neurological outcome, which was defined by the cerebral performance category 1 or 2. And then they also looked into the fast defibrillation within 90 minutes. So they categorized the patients into 3 groups. One is the patient with no bystander CPR. The other one is the bystander CPR without dispatcher assistance. And then patient received the bystander CPR with dispatcher assistance. So what they found, for the result, there was over 25,000 patients were included in this study. And then of those eligible patients, bystander CPR without dispatcher assistance was provided in 12.5%. And then bystander CPR with dispatcher assistance was provided in 47.8%. So nearly the half of the patients actually received the dispatcher assisted bystander CPR. So what they found was, not surprisingly, loss within 90 minutes with survival to hospital discharge was more frequent in the bystander group, and then both bystander CPR group, with the dispatcher assistant or even without the dispatcher assistance. And then the loss with good CPC and fast defibrillation within 90 minutes were also more frequent in the bystander CPR group, even without the dispatcher assistant group. So they did this analysis, and then they compared with no bystander CPR group, adjusted odds ratio for the loss with survival was 1.51 in the non-dispatcher assisted group and 1.63 in dispatcher assisted group. And then compared with no bystander CPR group, both type of the bystander CPR group were associated with 44% and 55% increase in the loss with survival. And then also both type of the bystander CPR group were associated with increased in loss with good CPs, good neurological outcome study. So the bottom line is both bystander CPR with and without dispatcher assistance were associated with really good, with a high frequency of the loss and then being discharged to home discharged with good neurological outcomes. The interesting is that I think they did not compare, the bystander CPR group with and without. I mean, they compared it with the non-bystander CPR group. So I don't know what is the actual impact of the dispatcher assistance with this case. But either way, I think providing the bystander CPR is the key factors. And then I don't know, layperson does not know how to perform. They don't know how to perform the CPR. So I think that they would like to implement this dispatcher assisted CPR nationwide, and it looks like it's really doing a good job on some of the resuscitation of the patient.
Yeah. Yeah, the big thing to take from this article is whenever I look at articles, I think about, do I have patients like their patients? Are their patients like my patients? Do we have males and females? Yes. Do we have people of different ages? Yes. Do we have people in cardiac arrest with comorbidities? Yes. And what is the outcome? They're looking, is their outcome something that I care about? And they were looking at people who survived to leave the hospital, walk in, talk in, live in their regular life. And that's very important. If we get people to the hospital and they do no better than if we left them on the street, then it's really not helpful, And that's sort of the problem right now with cardiac arrest is that, we're trying to figure out who has the best chance, who can we actually help.
Just something I thought was kind of interesting that they mentioned briefly, but the guidelines in 2015, which is right in the middle of their study, actually changed. And part of those 2015 updated guidelines include new guidelines for dispatcher assistance to a layperson, where they're actually increasing the amount of cases that they're going to actually instruct lay people to do CPR on an unwitnessed cardiac arrest. So I was kind of thought it was interesting that they didn't mention it fully, and I don't know how much it would affect the results, but it's something that.
No, absolutely. Those things affect the results tremendously. So. Next.
Okay, kind of a related topic. I covered the paper that hopefully I'm going to say this right. The Bokuto, is that right? Bokuto.
Bokuto, yeah.
Bokuto. Yeah.
In Japanese, right?
I think so.
Yes,
Yeah. Okay.
I think it's the name of the place.
Okay, so this paper, the title is it's a North American validation of the Bokuto criteria for withholding resuscitation during a non-traumatic out-of-hospital cardiac arrest. So we should probably start with what the Bokuto criteria are. So if you're Bokuto positive, that means your age is greater than or equal to 73 years old, you had an unwitnessed cardiac arrest, and it's a non-shockable initial rhythm with the AED or defibrillator. So those are the kind of those are the criteria that they were looking at, and essentially they wanted to see applying those criteria retrospectively to out-of-hospital cardiac arrest data, whether or not we can determine an appropriate group of people to withhold CPR from, meaning if you meet any of these three criteria, all three of these criteria, is it worth it to give over the EMS hours and the supplies to try and resuscitate when the likelihood of having a meaningful outcome, meaning return of circulation and or return of neurologic function, is highly unlikely. So they, they looked at, it was 26,000 people in the initial trial that they retroactively took data from, and 21% of them were the Bokuto positive, and only 0.51% had a favorable neurologic outcome after undergoing resuscitation if they were Bokuto positive, and 1.2% survived. So pretty low rate of survival and even lower rate of favorable neurologic outcome, and a pretty high positive predictive value of 0.995. And then they also looked at EMS and hospital-based resource utilization per favorable neurologic outcome, and it was 91 hours and 199 days. So 91 hours of EMS utilization and time, and 199 days of hospital time for the Bokuto positive group, for them to have any sort of improvement or outcome. And then it was only 5.7 hours and 33 hospital days for those who were Bokuto negative. So basically, all of this is to say that if you meet all three of those criteria, you're greater or equal to 73 years old, your arrest was unwitnessed, and you had a non-shockable initial rhythm, maybe we should consider terminating before we even start, because we're spending valuable time and man hours when the majority of these patients are not going to have any sort of meaningful outcome as a result of undergoing cardiac resuscitation. And I have to say, I think this is something that I can get behind for sure, especially in the wake of having reviewed mentioned last week, reviewing the EPI article and how, like, what are we valuing as a result of the outcome of a cardiac arrest? If it's getting a pulse back, but you're, you know, in a vegetative state, who does that benefit? And, you know, everybody is entitled to their own opinion and their own choices in terms of, like, religion and beliefs and that kind of thing. But for me, if I can't have a meaningful conversation and somebody else has to take care of me, I can't feed myself, I can't bathe myself, that's not a life that I want to live. And I feel the same for my loved ones. And so if I were in this situation, I wouldn't want to be resuscitated. And I think it's just worth serious consideration.
So I was unfamiliar with this criteria before this paper, and it's exactly the same things that we've been talking about. So, you know, we talked about on the other side, not necessarily who do we not resuscitate, but who has the best outcomes. So what are the criteria? There's usually 5 things. I'm not going to remember all 5, but, you know, what's the first one? You can get the first 3 by just what we just talked about.
You're talking about who we were, sorry,
Yeah,
repeat the question again?
who has the most favorable outcome for cardiac arrest?
Oh, if they have a shockable rhythm.
Initial
like
rhythm
it's a
is
witnessed arrest.
Witness arrests, yeah.
Immediate bystander CPR.
Yep.
The other 5
I
are.
assume younger patients as well.
I don't think that's part of the criteria,
I
but
don't
yes.
remember what the other 2 are.
Yeah, but those are the things that, you know, we've been talking about for the last couple of years is, you know, who has the most favorable outcome? It's that initial shockable rhythm, immediate CPR, and witness. And that's sort of the problem with some of our research has been that, you know, we just take all comers. You know, we don't differentiate the person who has the witness arrest versus the person who has the unwitnessed arrest. And that unwitnessed arrest, they could have been down for 20 minutes before we got there. So we're not bringing that back. So.
In the last month, I've had 2 very young people have an unwitnessed cardiac arrest, unknown downtime, and neither one of them made it. I can't recall a time when I've had a patient who had an unwitnessed arrest that I was able to get ROSC on.
Even if you do, I mean, most of those patients that we do get back have an anoxic brain injury.
Oh yeah.
Yeah.
I think once in residency, I got a young patient back. The benefit of that was that we didn't know anything about this young man or who his family was, and so we were able to find some identifying information after the fact, after we got ROSC, and so his family was able to come and say goodbye at least. So I don't regret doing that, but they definitely, I mean, they terminated, you know, they extubated him and he passed away almost immediately. So, yeah. Cheery topic.
Okay. Next article. You.
Okay, so I had the existing science on human factors and ergonomics in the design of ambulances and EMS equipment. So slightly different topic than those 2. So basically, the point of this article, it looked at EMS and just basically how they differ from average people. They are at higher risk for injuries compared to normal people. They're at higher risk for like low back injuries, and they were trying to review all the previous articles that were written and extract data on a few different points that they had. They used 3 databases, Embase, Scopus, and PubMed, and they basically, of 4,000 articles, they were able to get 48 relevant articles that they sorted into 3 categories. So they basically just looked at general design, patient handling, and patient transport. And they say that basically in 2002 an article was written on a hidden crisis, and they're saying that there basically isn't much research. And even after reviewing all of these 4,000 search results and making it into 48 articles and looking at those articles, it still shows that basically there's still not enough research. That even though after the past 15 years, like more research has to be done and more resources are needed to see exactly how we can make. Ergonomics is basically the efficiency of how you can do your job. So basically, we need more research to see how we can help EMS personnel do their job. I mean, it's difficult to go into like the exact specifics of like how they did this, but they had reviewers looking at the article, seeing what they thought was necessary, and they basically just discussed it until they got to a decision. But I feel like the most important thing to take out of this is how difficult it really is to do this research, especially within like all the different EMS systems. Like, you know, there's Monarch, there's so many other ones, and you know, there's other ones in Jersey, and then there's different people that are in charge of making these regulations, and then there's the concept of, do we want people to make regulations or not? Because once you have someone getting in and regulating that you need this type of seatbelt or you need this type of equipment, then they can regulate other things that you're doing within your EMS system. But I think it is something important to do more research on, because I mean, I didn't have much pre-hospital exposure before starting residency and starting this rotation. Last week we had a case where, you know, we had a cardiac arrest, and then the patient kept losing pulses while we were en route to the hospital, and you know, we had somebody doing compressions. Like when I was doing compressions, someone was holding me by my jacket, and these are all factors that I, you know, never really thought of before coming onto the field. So I think that's part of the issue, is that the people who make these products, they don't really have that much insight into what goes on a day-to-day basis. And that's part of what the article talked about, is that there's a big gap between the companies making these things, and you know, it is a great, like Navin and I talked about this, you know, if there's these cables that they have that can, it's like basically like a bungee jump that hooks you onto one of the top rods, and so that way, you know, if you are like in an accident while you're trying to do compressions or not secured in, it'll basically lock and keep you from doing that. But the expense of some of these, you know, newer products are things that not every EMS system can afford. I think, you know, we've done a lot of research within like having this big Monarch database, like with our D50, D10. So, you know, that's something interesting that we can potentially look at in the future, of using our own database to get more research and see how we can improve the ergonomics of EMS. But at the end of the day, it's a tough topic, because it's all going to come down to what people want to do, right? Like, even if we get the best bungee cord cable to keep people in, are people going to follow it and actually use their seatbelt? Are people going to use these devices to help carry and lift people? I don't know, probably not. Some of the old medics who are like, you know, used to doing things the way they did it for X 20, 30 years, they're not really going to change it much, and I don't know how much difference you can make, but I guess once you start the research, you can really see what you can do about the topic.
There's a lot of controversy in this, even in New Jersey here. There's a huge controversy about the ambulance track system, where they bring the bed into the ambulance to secure it to the floor. The newer system is a track system, or a rail that's mounted to the ambulance floor, versus the old like antler horns that you had before. And I think they just started some regulation that every new ambulance that gets licensed in New Jersey needs this track system. It's very expensive, and the regulation doesn't retrofit all the old ambulances with this better thing, but it does require any newer ambulances to have it. And this is huge controversy, because it puts $15,000 extra on the cost, and we've been hearing about this over the last year in different meetings around the state, and it's tough to make any change.
It's tough. And then whatever
Fixing
money,
these problems.
like say they make like this regulation that they made, now every ambulance has to have that. Now these are who exactly, if they're making the regulations, who's funding this? And if it's required of the individual person, like Monarch, to fund this, then we're losing funding on other things that we may want to do. So then, you know, it's difficult to figure out exactly what's going to happen with that.
Most of the time, Monarch is not the transport, so we're relying on the other agencies that we interface with. You know, some of the volunteer organizations in wealthier areas may, like gladly invest in something like this, but when we get to the like the smaller professional companies that are in vans with much older equipment, there's absolutely no chance of it.
Right.
And I'm guessing it would further dilute the data, because some of the time we're in like cutting edge ambulances, and other times we're using stuff that's 20 years old. So
And that's the thing, that like this data, it's talking like, even if you're trying to compare like using other safety devices, it's like you said, differs from like what kind of area and the funds that you have, but also like you can't really compare like EMS systems out like Midwest, that they're in like rural areas, that like the chances of them having a collision is going to be much different than when you're trying to navigate like the streets of Newark, and there's pedestrians and cars and stuff everywhere. So it's a lot of factors that all go into it, which will be difficult to navigate. So
And the biggest thing is that, you know, we design ambulances to transport and treat patients, and you know, it's kind of like the afterthought. And now we're coming around and saying, okay, we need to make them safer. So there's definitely research out there. We reviewed a couple articles. There's only a couple people in the country. There's just a handful that are specifically looking at this. One of the big things that have come from that research is, you know, the captain's chair right at the top of the head of the bed is usually the safest if you use your seatbelt. The other thing is, don't mount the oxygen right behind that chair, because when you shear a high pressured tank, the top off, it becomes a projectile. How you secure them is also very important. How you secure the patient to the stretcher, you know, having the top straps, having at least 3 points or at least over the different stress points really makes a difference. And sometimes that's not possible. Using a mechanical CPR device when you're transporting a patient who is in cardiac arrest makes it safer for the crew, but the clinical data isn't out there to make it worth it clinically. But in terms of a safety standpoint, it's definitely safer to have a mechanical device doing CPR and not you over the patient. These straps that she was talking about, you know, they're kind of like, if you ever see the people who like do like construction, they like hook in, it's very similar to that. And then during an accident, it's also on a pressure system where it basically pulls you back and holds you in place. So personally, I've always preferred being in a van ambulance because that's what I grew up on as a medic. And at any given time, if I just put my arm out, I'll hit something, versus the box where you can fly for a long time before you hit something and then you hit it really hard.
Yeah, but resuscitating somebody in the back of the van.
Exactly. So everything has its pluses and minuses. Also, what's nice is some of the bigger ambulances, you can mount your equipment. So they have like a life pack can be clipped right in, which is very nice, instead of being seat belted in to wherever you can find it. And also having that spot where you can go every single time and you know that that's where it is. So it's something to think about. And this goes along with the Mercer article that we talked about 2 weeks ago, where they swab like the oxygen tank and they swab like the handrail, and you know, you find all these different bacteria there. So things like that. Last article.
Yeah, so this last one was from Dr. Ferguson out in Liverpool Hospital in Australia, and it was actually a literature search. It's an interesting research topic. It says, does the addition of fentanyl to ketamine improve hemodynamics, intubating conditions, mortality, and the emergency department intubation? And this was a systematic review. Usually these things are like meta reviews, but the problem with this is you can't do a meta review if you only have one paper. So this guy went through thousands, the team went through, let's see here, 3,500 articles in their search, and they ended up only finding one observational study in Japan that started comparing and contrasting fentanyl and ketamine inductions and looking at the hemodynamics from it. And at the end of the day, the moral of the story is, just to quickly summarize the article, is this systemic review actually highlights how much there is no literature and there is no research into this topic, and we have to start looking into that. I mean, the introduction through the paper goes through great, saying how important it is to have to manage, you know, the patient before you intubate them, how it's important to watch their peri-intubation hypotension and whatnot, and first pass success, and I looked at all those different things, and there's a great introduction to that. And then the methods, how they went through and they did the literature search through all the regular things that they normally do, all the different databases, and they could only come up with one paper that looked at fentanyl. And really that's pretty much it. I mean, my personal practice is I give ketamine, rocuronium, and fentanyl all at the same time with the inductions, and have pushed those pressors readily available to avoid that hypotension period. And in my experience, it usually goes very well, even given 10 to 40 micrograms of epinephrine in the peri intubation if their shock index is high, to avoid the hypotension. But it's not just getting the tube in on the first shot, it's actually avoiding hypertension, bradycardia, hypoxia, hypercapnia, and all that good stuff in the induction.
Dr. you want to say something? No? Okay. That's what we've been talking about for the past couple of years, is that, you know, when you're intubating someone, I'm not worried about how many attempts that you do. It's avoiding the hypotension, avoiding hypoxia. And, you know, if you can avoid airway trauma, that's helpful too, especially, you know, I'm like the 4th try. So, you know, when I go in there and I'm just like, what did you guys do? But I haven't had to do that in a very long time, so I'm happy about that. And I give them fentanyl because it, you know, it hurts. Like, it hurts to put a piece of plastic down your throat. The ketamine helps. I don't know if it really helps with the hemodynamics if you use less of it. I prefer to use less drugs than more drugs. So these drugs, the ketamine, the fentanyl, and whatever else you use, the rocuronium, each of them has a purpose. And adding, you know, more to the mix is just gonna make things worse.
Yeah, I mean, that was one of the things that he highlighted in the article. I mean, there is no absolute one magic bullet to cover every situation. I mean, the closest thing we come to it is ketamine. But by and far, we've accepted it in this program, and it's coming across through the literature as well. But everything, all these sedatives cause hypotension. Ketamine, they say, causes hypertension. You know, it can cause increased heart rate, increased blood pressure. When in some head injury patients, they debunk that through the research because your ICP flow, you know, your cerebral perfusion pressure increases as well, so it kind of mitigates the rise in it. But they're saying to blunt that rise in the heart rate and blood pressure and ketamine inductions by giving fentanyl, and that was part of his research thing, and it really couldn't find an answer to that question with this paper. The other portion of it is when you're catecholamine depleted and you give ketamine to somebody who is shocked, it drops your pressure down. We've all seen that in our practice too. So having that push dose pressure ready to go at the bedside, even giving it empirically before the hypotension sets in, if you have a high shock index, is really my practice, and I think everybody else is on the same page as well. You really got to customize and tailor your airway plan and your induction plan for every situation. Resuscitate your patients before you induce them, especially if they have a high shock index, because they will crash and die. And it's the path to securing the airway that's important, and not just putting it in the first shot. So I agree with that. I think Dr. Ferguson said as much too. They just unfortunately didn't come up with, you know, what that is.
And especially when you know what drugs you have, you know, on the ambulance we're a little bit more restricted because we only have what we bring.
Right.
So you need to know the drugs that you have, how to use them. If you have a replacement drug, like sometimes we have shortages and they put out replacements, you know, you should become familiar with that drug and the side effects and how it works and how you need to adjust. In the hospital, we have a little bit more of a bigger pharmacy, so we should be ready to substitute immediately, you know, based on what's available. And then pre-oxygenation, everything like that.
I mean, the big points to take home that we've been stressing through our journal clubs and all this data and all the papers we've always done is having a solid plan going into an airway emergency. Resuscitate your patients before you induce them. Pick your sedatives to match your patient that you're going into. And remember, sedatives drop your pressure. So if your patient's hypotensive, high shock index, you know, having the mantra in your head, half the sedative and twice the paralytic, is important because the paralytics are peripherally metabolized and need to be out into the periphery, and your sedatives are going to drop your blood pressure regardless. And if they're that shocked, their perfusion to the brain really isn't there anyways. So very little sedative is effective enough to get the job done. So so the mantra is a good plan going in. Half your sedatives, twice your paralytics when they're hypotensive. Resuscitate your patients before you go into an airway situation, and have push dose pressors ready to go. Give them empirically if you see, you know, if you predict peri-intubation hypotension, because I think what triples your mortality is what we came up with, or 50% increase in mortality for one episode of peri-intubation hypotension. And now in this case, their search criteria is they said half hour before or after the induction. And
Yeah, but that study was over in 24 hours even after intubation. Yeah.
So I mean, one episode of intubation hypotension destroys your mortality for that, or grossly impacts your morbidity and mortality.
So Jose, one of our medics is asking, what's a good alternative to ketamine for sedation of the combative TBI patient?
Well, again, I'd still go with ketamine, and this paper they were talking about was cutting the ketamine, or cutting some of the hypertensive, tachycardia responses with fentanyl, with this, to blunt that, because the fentanyl does in higher doses we've seen in other papers, and we're talking to the orders of 5 to 7 micrograms per kilogram. I mean, it's like 5 times the dose of a normal. So you're given 500 micrograms or 700 micrograms as a pretreatment for head injured patients. There's a couple studies we looked at, and really, at the end of the day, didn't come up with it. We're not given that high of doses. The head injured TBI patient that they're concerned about that you're giving ketamine to, ketamine, yes, will increase their heart rate, yes, will increase their blood pressure, but it also increases their ICP, and that cerebral perfusion pressure increases. So it's kind of a wash on that, because you're still perfusing the brain, but it increases the pressure a little bit. It does come down, it is temporary, and the papers we reviewed in the ICP studies where they put bolts in the head and measured their ICP in real time, no increase or no change in morbidity and mortality of those patients. So in my personal preference, yes, I would give ketamine to pretty much just about any person that I'm going to intubate and induce. I give fentanyl as well, but my package usually is 2 milligrams per kilogram of ketamine and paralytic, plus 100 micrograms of fentanyl, all given at the same time. And have your push dose epi either given or in your pocket ready to go. I would even give it at the same time too, if their shock index is elevated, greater than 1, because they are going to crash and the pressure is going to come down. So to get ahead of that is so important. I hope that answers the question. So I mean, etomidate is also an option too. I mean, there's nothing wrong with etomidate. You just have to be careful in your sepsis patients. I mean, I think that's still kicking around in the literature that if you're in septic shock and adrenal suppression and all that, but you can also give, Cyclortef, 200 milligrams of Cyclortef in a shock resuscitation goes a long way as well. But again, I mean, that's...
Don't have that on the ambulance. Though.
Yeah.
All right, and that basically wraps it up for Journal Club today. We're going to be a special Journal Club next week at North Arlington. They're hosting us next week, so join us at 1300 hours, and that's it.